to have Dr. Friedman Ross with us today, and she's going to be speaking on predictive genetic testing and carrier detection in children and adolescents. Thanks.
Thanks, Maureen. I have to tell you, I love where I work. I work at the McLean Center, but every year for 2 days in July, it is so wonderful to come to a warm and fuzzy place where everybody cares about ethics, but about pediatric ethics. So this is a really special place. I want to thank the organizers for inviting me back, and as long as they keep the Diet Coke, I'll come back every year. What I want to do today is challenge current policy. So you can see the X's and the checks. So for newborn screening, as a mandatory program, I have an X here because, as my questions to Dr. Alexander yesterday suggested, I'm not convinced that any of it needs to be mandatory. I think we can respect the ability of parents to know that testing for conditions for which early treatment exists is the right thing to do. Clearly, everybody supports diagnostic genetic testing. You have a child who's failing to thrive and is having pulmonary exacerbations, and your first thought is CF, and you do a sweat test, and in a sense, you're doing a test to confirm a diagnosis so you know what treatments to give. But what I really want to focus on today then are the bottom three issues, which is predictive genetic testing of children is considered taboo. I want to question that assumption. Carrier testing is considered taboo. I'm going to question that assumption. And the last thing I'm going to is going to be a flip, which is I'm going to question our policies, which actually will lead into next year's conference very well, which is I'm going to question the right and responsibility and abilities of adolescents to consent to predictive genetic testing and carrier testing for themselves. So let me begin then with the whole issue of predictive testing is taboo. There's a wonderful article by Rick Kodish, published in 1999 in the Journal of Pediatrics, which basically said we should not test a child for a genetic condition for cancer genes, for example, until the child is of an age where they can be at risk. So, for example, we shouldn't be testing for breast cancer genes until 5 years before the first family member had breast cancer and things of that sort. What this rule fails to consider, however, is that some cancers present in adolescence. And so, for example, there's a condition, familial adenomatous polyposi, presenting with numerous polyps, which will eventually turn cancerous. And what this is suggesting is that we're not allowed to test that child until around age 10 to 12. And I'm going to challenge that and ask why it would be wrong for the parents to test a child much younger. It also fails to acknowledge that there are some cancers that are treatable and that we actually have to test these children in order to be able to screen for them effectively in childhood. So again, looking at different conditions that we can look at, for illnesses that present in early childhood, we have the curable cancer of retinoblastoma. If we know that the child has gene positive, we're going to be doing every 3-month eye exam, looking for the fact that the cancer has occurred, and then we'll be able to enucleate or treat the eye at that time. But we also have the whole question of predictive genetic testing for incurable diseases like Duchenne's muscular dystrophy. We can look in adolescents for FAP, as I've already mentioned, which can be curable if picked up early, as well as incurable conditions of Charcot-Marie tooth. And finally, when we look at predictive genetic testing, we have to consider conditions that present in adulthood, like breast cancer and Huntington's. So to just have this lumped policy that predictive genetic testing in children is taboo, in a sense, ignores the fact that there's a lot of different types of predictive genetic testing. There's predictive genetic testing for both early and late onset for curable and incurable diseases. So these are the 3 examples that I want to look at today: retinoblastoma, Duchenne's, and FAP. So retinoblastoma can occur as a new mutation, but in families there is an autosomal dominant inheritance. If diagnosed early, it's treatable, although the eyes may or may not be salvageable. And the diagnostic method will be to do frequent eye exams for children at risk. Now, before we had a genetic test, if you had a father or mother who had a retinoblastoma as a child, doctors would take your children every 3 months to do an eye exam, and that becomes hard between 1 and 2 years of age. We often take you to the operating room to do it under anesthesia, and you would do this until the child turned around 4 or 5, and if the child never developed a cancer, we could say for sure that the child wasn't going to develop this disease, although the child could have still been a carrier. It's only about 90% penetrant. But nowadays, we have the gene test. So if we test a child whose parent has retinoblastoma, 50% of the time we could avoid all of the unnecessary diagnostic testing, which includes anesthesia, which is not necessarily benign. So here's the case. RB is a well-appearing 6-year-old boy who you're meeting for the first time. The family history is remarkable for dad having retinoblastoma as a child, and his left eye was enucleated. You recommend genetic testing to determine if the child is risk. And the mother states, you know, we were offered that prenatally and we said no. And now they're refusing postnatal testing. And the two questions I ask is, why might the parents have refused prenatal genetic testing? And what should you do if they refuse now? So I think it's important to realize that to test this child prenatally may have been a decision about whether or not to terminate a pregnancy. This family clearly had no interest in that. But testing the child postnatally is about making appropriate diagnostic decisions for the child. And so the parents need to be educated about the difference. For most parents, I absolutely agree that it makes a lot more sense to test the child as a newborn and not expose the child to any risk from the amniocentesis. But so what do you do if the parents refuse prenatally? Can they? Absolutely. But can the parents refuse testing now of their newborn? And the answer is they can. They can refuse as long as they're going to do the old-fashioned way. We're going to test all of their children every 3 months with an eye exam. And if the child is positive, the child would have gotten these exams anyway, so it's not really different. Although they are exposing their negative gene-tested children, their children who would have had a negative gene test to unnecessary exams. And yet I would argue there might be reasons they don't want to do the gene test. They might not want to do it because they don't want to increase their anxiety. They might prefer not knowing. They might not want to get a gene test because despite the new legislation, they might be concerned about discrimination. But they still have to get the eye exams. And in fact, in pediatrics, if parents would refuse to get this, we would view them as being neglectful, and we would actually call in and argue that the parents were medical neglect and get DCSF custody to do those very frequent eye exams. So even though they have a right to refuse the genetic test, it doesn't mean that they have the right to refuse to get their child the appropriate medical care for this potentially lethal genetic condition if not treated early. Let's contrast that with Duchenne's, which is an X-linked condition which presents usually in toddler to young children in starting to develop muscle weakness. By the time these children are in the ages of 10 to 20, they start losing the ability to ambulate and will often need either to be ventilated or will die eventually of either cardiac or respiratory failure. So here's a family who want testing for Duchenne's muscular dystrophy. It turns out that mom's nephew was recently diagnosed at 6 years of age, and mom has been found to be a carrier. So her risk for her son is that he has a 50% chance of having Duchenne's. So what are the pros and cons of testing? Well, we could say that for some parents, once symptoms develop, we can avoid this medical odyssey. Some parents and some physicians will want to start steroids early if they know that the child has the gene. So those are some of the pros. There are also cons of testing because now when the child starts walking at age 2 and trips, which is very common in every single 2-year-old, the mom is going to sit there and say, is this a typical 2-year-old or has the Duchenne's kicked in? And so we can imagine the vulnerable child syndrome being a real probability. Looking at it, though, there are also the pros and cons from the family's perspective. Am I going to buy a house with stairs? Am I going to buy a ranch house? I might be able to handle one child who's going to have physical disabilities, but I might not feel comfortable that I have the capability of taking care of 2 children in a wheelchair. So it may change the parent's own reproductive decision-making. So can the parents refuse testing prenatally? Absolutely. Can parents refuse testing of their newborn? Absolutely. Can parents demand testing of their newborn? Well, if we go by this rule of earliest onset, we wouldn't allow them to test. And yet I've argued that there are both some medical as well as psychosocial as well as potentially for the family reproductive reasons why we might want to. There are also negatives. And that's why I'm not going to say absolutely or never. I'm going to say let this be a decision that the family should make. But I think we should realize that with this whole notion of expanded newborn screening, are we screening newborns for Duchenne's? And the answer is yes in several countries around the world, including Wales and Belgium. And currently, there are 2 research pilot studies being funded by the Centers for Disease Control, a newborn screening pilot program for Duchenne's in Ohio, and one of screening infant boys at 6 to 15 months in Georgia. So the fact is that as we start moving into this, we have to think about it from the newborn screening program. And again, it's going to push me to ask Dr. Alexander and those involved in newborn screening policies at the federal level to consider changing our policies to consent for all different newborn screening. Big difference then between retinoblastoma versus Duchenne's. And I would say that when there's an early onset condition that's treatable, diagnosis is viewed as medically imperative, and refusal can be perceived as neglect. When an early onset condition is not curable, the diagnosis is viewed as elective. When symptoms appear, the diagnosis becomes important in order to rule out treatable conditions and in order to know what therapies we need to give to this child. That's looking at predictive genetic testing for real early onset conditions. Now let's look at some early onset conditions that present in adolescence. So FAP, as I've already explained, autosomal dominant with almost complete penetrance, presents in adolescents with multiple polyps with developing cancer 10 to 20, 30 years later. And so the treatment then is actually to do a total colectomy. So what are the pros and cons of predictive genetic testing for conditions that present in late childhood? So what would be the pros and cons of wanting to test my 6-year-old for whether he will develop FAP at 12 years of age? Well, one pro is that 50% will test negative, and it can relieve my anxiety. But for even those who test positive, it relieves ambiguity. There have been a lot of studies coming out now about predictive genetic testing, both for childhood, adolescent, and adult onset conditions, that shows that knowing your family history is actually very stressful. We used to always talk about how important it was. You don't have to do the test, you just have to share family history. Well, a lot of data are showing that when you know your family history and you test negative, you feel about this good. When you know your family history and you test positive, you feel about this good. When you know your family history and no one lets you get tested and you're living in ambiguity, you took your MCATs and every single day you're waiting for your score and no one's going to let you know for 6 weeks, you feel this good. And so living in ambiguity and knowing family history may be the worst thing that we can do for our children. And so I really do think that one of the biggest pros of a parent deciding to do this test for their child is that they're removing their own stress of the anxiety of living in ambiguity. What are the cons of testing this child? It takes away the child's, quote, right not to know. Now I'm going to ask the question, though, does the child really have a right not to know that he or she is at risk for FAP? If the child or the parents refuse to have this gene test, just like with retinoblastoma, we would say, well, if you refuse the gene test, then you have to get screening. And the screening is, starting in middle adolescence, we're going to do a colonoscopy. And we're going to do it because if your parents refuse it, it's medical neglect. So you have the right to refuse a blood test, but you don't have a right to refuse a tube up a very personal part of your body. I would think the tube is probably a lot more invasive than the blood test. And so the concern, though, is that if I do test this 6-week-old, and we wouldn't start colonoscopies until middle adolescence, that these parents may be so anxious that their child's going to develop cancer that they're going to want to demand colonoscopies at 8, at 9, at an age where these children will not have developed any polyps. That's always a concern, although the data from the MEN2 and the thyroidectomies suggest that parents really are not demanding inappropriate medical care when they get positive gene tests in the early infancy period. So how would I revise our policies for conditions that present in childhood? First, it should be noted that all the statements by the American Academy of Pediatrics, the American Society of Human Genetics, even by the working group in the UK, all of them say very little about conditions that present in childhood. Their real focus about predictive genetic testing is about conditions that present in adulthood. But let me talk about, though, let's start with the predictive genetic testing in childhood. I think that for retinoblastoma, predictive genetic testing in high-risk families should absolutely be encouraged. It can avoid unnecessary testing of those who test negative. But I would not support routine screening of the general population. For Duchenne's, predictive genetic testing in infancy should not be routine. But again, in high-risk families, if families want it for family planning, for medical planning, for social planning, I would absolutely be supportive with appropriate counseling. For FAP, although the consensus position is to wait until the child is 10 before you do the gene test and to let the child have a role in the decision-making about the gene test, it's not clear, actually, whether the child has the right to refuse. I hate policies that say let the child be involved, and then when the child gives the wrong answer, we ignore them. If we're not going to really respect the child's refusal, then why are we asking them? So even if the child can refuse the gene test, they're going to end up with getting a colonoscopy or a tube up their butt. And so I'm not convinced that this is really a decision that we're going to leave, even to the child who seems very mature at 10 or 12. But now let's go to where the policy statements really are in predictive genetic testing for late-onset conditions and use these two examples, the breast cancer gene and Huntington's disease. So here are the positions of the various medical societies. The working group from the UK wrote, "The Working Party believes that predictive testing for an adult-onset disorder should generally not be undertaken if the child is healthy and there are no medical interventions established as useful that can be offered in the event of a positive test result." Of note, the family support group, the genetic interest group in the UK, supports this conclusion. In the American side, the ASHG and the ACMG, they had a statement a year later, and they said, if the medical or psychosocial benefits of a genetic test will not accrue until adulthood, as in the case of carrier testing or adult-onset diseases, genetic testing should generally be deferred. So everybody's on the same page. But then they said this, the balance of benefits and harms is uncertain. The provider should respect the decisions of competent adolescents and their families. So that's starting to suggest, maybe the Americans are saying that when we're uncertain about the benefits and harms, we let the family decide. That's what it looks like. But then you go to the next paragraph, and it reads, until more information is available regarding the risks and benefits of genetic testing, the provider's guiding principle continues to be primum non nocere, first, do no harm. Thus, when faced with uncertainty, the provider may be obligated to avoid the possibility of harm, rather than to provide unclear benefits. So on the previous slide, when we're not sure about harms and benefits, let the family decide. On this slide, when we're not clear, the doctor should avoid harm, even if the benefits may exist. This may be rebuttable presumption to defer testing until the risk-benefit ratio is favorable. So although it looked like we were going into a let the family decide, we ended up back to the same position as the Working Party. The American Academy of Pediatrics holds a similar position. Genetic testing for adult-onset conditions generally should be deferred until adulthood or until an adolescent interested in testing has developed mature decision-making. And I'm going to ignore that part until I talk about the adolescent's role in making decisions. But the AAP continued. The AAP believes that genetic testing of children and adolescents to predict late-onset disorders is inappropriate when the genetic information has not been shown to reduce morbidity and mortality through interventions initiated in childhood. In other words, if there's no treatment, parents have no right to this information that will not affect their children until they become adults. All three statements are in relative agreement. So I'm going to question all three statements. Now I get to fight internationally. Excellent. So let's look at these two conditions, BRCA and Huntington's disease. So the age of onset for both conditions is similar in the 30s and 40s. The gender, the male-female ratio is equal in Huntington's disease, mostly women in breast cancer, although men and women have an equal reproductive risk of passing it on to their children. Huntington's disease testing is pre-symptomatic, meaning that virtually everyone who gets the gene will go on to have the condition, in contrast to BRCA, which is predispositional. If you have the gene, you have somewhere, depending on your family history and ethnicity, a 30 to 80% chance of getting the disease. So if you have the HD gene, we know you're going to get the disease. We don't know that's the case with BRCA. And of course, the other major difference is there's no treatment for HD versus with BRCA, we can do early screening. We can even do prophylactic surgery. And I think the public understands that difference because the percent of at-risk community that seeks testing is much higher in BRCA. It's probably higher than 50%, versus Huntington's disease, which we know is between 10 and 15% of those who are at risk who seek testing. So what are the pros and cons of predictive testing for adult-onset conditions? Always 50% will test negative, so we can relieve anxiety. But even if you test positive, at least we're reducing your ambiguity. And it's the possibility of incorporating this into your life plans. You may decide to have children early with breast cancer. You may decide not to have children at all. What are the cons? First, it takes away, quote, this child's right not to know. The concern is also that the parents may seek inappropriate screening or unproven and potentially harmful therapies. There's also the potential for employment and insurance discrimination and concerns about the harm to self-identity. So what's the argument not to do it in children? Well, it's not clinically elective. And so I think we should think about it more as akin to an elective procedure. There are psychosocial risks and benefits of knowing one's status, both for the child and for the family. But I would go back to that first statement by the ASHG, that how are we going to balance that benefit-burden ratio is we're probably the families better than the clinicians in deciding whether the benefits or the burdens outweigh the other. Nevertheless, I think when families are considering this, that they need to be encouraged to consider the child's interest as paramount. However, this does not mean that we have to totally ignore parents' interest in this. The child's status may impact the parents' reproductive plans, and the parents have a known 50% risk that this child and each subsequent child will be affected. So lots of reasons not to do it. It's interesting, as I said, there's much greater concern regarding predictive testing for these adult-onset conditions, but actually there's a lot of unknowns about the psychosocial impact given the time between testing and the risk of disease onset. There's always also this concern for privacy. For childhood onset conditions, the concern of privacy appears to be less because the fact is that if I don't test the child at 2 for the FAP gene, I'm going to test my child at age 12. So the child really doesn't have a right to privacy against the parent because the parent has to make healthcare decisions for the child during their minority. In contrast, if I don't test my 2-year-old or my 12-year-old for BRCA, my child can at age 21 refuse to get tested. Not the greatest decision, given that this can be life-saving. If we know that the child is positive, we can start early and frequent mammograms and things of that sort. There's this suggestion by all of this that a parent's responsibilities end at age 18. Parents' rights to force their children to get testing may end at 18, but that doesn't mean that parents believe that their responsibilities have ended. If I know my child is negative, I don't have to nag her about getting her 6-month mammograms. If I know she's positive, I know I have a moral obligation as her parent to nag her. If it's ambiguous, we're both stuck. So I can see why parents may want to test their kid to be able to help guide their children. All young adults between the ages of 18 and 25 are invulnerable, or at least they perceive themselves to be that way. And it may be very useful to have a parent, particularly a caring parent, who wants to ensure that that child is getting appropriate medical care. And so basically that's what this slide is saying, that parents don't differentiate so clearly between this predictive genetic testing for early versus late onset conditions. And the responsibility and guilt about passing on the genes will happen regardless of the timing of disease onset. So what are my recommendations about predictive genetic testing for adult onset conditions? I agree, actually, that the presumption should be to discourage predictive genetic testing of children and adolescents for early and late onset conditions. But I don't agree that the uncertain benefit-burden ratio should be resolved against testing. I really think we have to leave this to the families. And I think what we're seeing in a lot of the empirical data that's coming out is that many families do want this information, and they are using it in appropriate ways. So we have two options. We can either let the physicians decide, which is where the ASHG, ACMG came down, or we could allow the parents, and it's clear that I'm opting for the parents. I'm going to move on then to the issue of carrier testing is considered taboo, and I'm going to question this one as well. If carrier testing of children is taboo, then the carrier status of all children should be unknown. Well, here's a problem. First of all, we're detecting it prenatally. If prenatal testing is done to detect a child with a genetic condition, carrier information is given to the parent, so then the child's carrier status is unknown. We're also detecting the newborn screening. Mandatory test, I don't even get to choose whether or not I find out that my child is a carrier. For sickle cell, and in many states that use the IRT DNA method for CF, whether my child is a carrier for CF as well. In fact, one can actually question if we really thought it was wrong that a child had a right to privacy about their carrier status, then all states should be using an IRT method. And the fact is that many states, including my own in Illinois, is using an IRT DNA method. So that's clear. Genetic testing for carrier status in child. Yes, we do detect it. The question is, should we? The assumption is that carrier status has no implication for the child's own well-being. Well, that's actually being disproven for both autosomal recessive conditions as well as X-linked conditions. So with an autosomal recessive condition like sickle cell disease, we do know that there are some health risks of being a sickle cell carrier, that those individuals are at greater risk of having a sickling crisis in episodes of extreme hypoxemia or an extreme dehydration. And so, I mean, we learned about this in the 70s when the 4 military recruits who died during military training without water bottles at the time all had sickle cell carrier status, and we've changed the way we actually do football practice and military training so that everybody carries water bottles. But clearly some children or some adolescents will need those water bottles more than others. So we have to acknowledge that being a carrier isn't totally benign. X-linked diseases. So being a carrier for an X-linked condition like Duchenne's muscular dystrophy, 10 to 20% of women who are carriers for that gene end up developing cardiomyopathy in young adulthood. Probably less, not always diagnosed, because unless you had a child with Duchenne's muscular dystrophy or family, no one may have even tested you for it. So we have to acknowledge that this carrier status actually may have health implications, and it may not only be about reproductive information. It also makes the assumption, if we don't test children for carrier testing, that reproductive implications is not needed till adulthood. And I wish that were true. But when we look at the statistics, we see that there are many adolescents, children having children. And so maybe they need to make some type of healthcare decisions for themselves and for their fetus. So what are the pros and cons of carrier detection in childhood? The pro of testing is that ambiguity, and I'll keep focusing on that, can be more harmful than many realize. That being a carrier may have more implications than previous believed. That in high-risk families, it can also serve to reassure parents that the child does not have a condition. So when we diagnose a child with CF, the parents are always looking at us and saying, for example, how do you know my 6-year-old doesn't have CF? And so we say we can do a sweat test. But parents actually prefer a genetic test because they get a negative sweat test and they're still not convinced. When they have a known genetic mutations, they find that having the gene test is more reassuring. Medically, I would disagree with them, but it does then also give them this extra information about their own child's carrier or their child not being a carrier, and therefore what they feel information they need to share about family health, family risk as the child matures. What's the cons about testing children in childhood? Well, the con is that the information has reproductive implications, and there are many people who refuse carrier testing prenatally. There's also the concerns about labeling, and we'll talk a little bit more about that. So what is the UK position? The Working Party and, again, the Family Support Group, the Genetics Interest Group, both are against genetic testing of adolescents for late-onset conditions. What's interesting is that the Working Party, so the professional group, was against carrier testing of adolescents, where the family group was actually in favor of it. They felt that the facts of life were better absorbed slowly rather than during a crisis over pregnancy, that the carrier status information is less intrusive on the adolescent's autonomy and confidentiality, and that individuals can still choose whether or not to use this information. So while we may have violated the, quote, child's right not to know, we didn't violate their right not to use this information. I was fascinated by this. I have to tell you, if you asked me which was a more personal decision in my life, how I'm going to die, predictive testing for a late-onset condition, or my reproductive risks of having a child who may have certain disabilities, I would actually think that from my own perspective, my reproductive information, because I can hide that from you. I can go through IVF and pre-implantation genetic diagnosis. I can choose not to have children. I could use a surrogate sperm or surrogate eggs. And so there are many ways that if I know this information about myself, none of you would have to know it. When I die, my obituary is public knowledge. So I was fascinated that the family support group in the UK thought that reproductive information was less sensitive, less intrusive about their adolescents. I have nothing to say. I don't live there. Nevertheless, I again will agree that the presumption should be to discourage carrier detection in low-risk families. I don't think we should go around and having population screening, and we shouldn't do, as Dr. Foss described, having television programs where we test you for sickle cell or cystic fibrosis carrier on TV. I would not encourage carrier detection in high-risk families, but I would respect family requests. I don't agree, again, that uncertain benefit burden calculations should be resolved against testing. I'm just going to let the families decide. But I am going to make a very strong opinion that I don't support carrier screening programs in the schools, and we'll come back to this as we look at the adolescent's right to make decisions for him or herself. So the last issue so I've argued now why predictive genetic testing may be okay, why carrier testing may be okay. The last thing I want to look at is this growing acceptance of adolescents consenting to predictive genetic testing and carrier testing for and by themselves. So the 14-year-old who comes in and wants to know if she's a BRCA carrier, even if her mother might not know her own status, but we all know that grandma was positive. Or the adolescent who wants to know whether she's a carrier for CF since she has a brother with CF type of thing. So in the Adolescent Requests Testing, the ASHG ACMG statement says, ensure that the request comes from the adolescent. And here's their quote, in the face of uncertain benefits and harms, an adolescent's request for a test necessitates an individual assessment of competence and voluntariness. So if the adolescent's asking, we have to make sure they're mature enough to be asking. Then they say, well, carrier testing may actually fall under the specialized consent statutes. Those are statutes individualized in all 50 states, which allow adolescents to seek certain medical care without their parents' permission, and that includes contraceptive, treatment for mental health issues, as well as for drug abuse. So if you view carrier testing as part of reproductive planning, you might be able to say, well, they should be allowed to get it under the specialized consent statutes. And in fact, others would say that some of the mature minor statutes may allow them to get testing by themselves. The working party is much clearer. They're not worried about it. They say if the child is over 16 years of age, the adolescent can consent, and GILIC competent, so again, having the maturity, the adolescent can consent on his or her own. And in fact, Canada and Australia have experimented on carrier status screening in the high schools. In Canada, in Montreal, there was testing both for Tay-Sachs, there were hemoglobinopathy screening, there's been CF screening. In Australia, there's also been CF and Tay-Sachs. And the data showed that the majority of the adolescents who get tested understood what they were told, but there were some significant misperceptions. So I have to tell you this very interesting article that showed that adolescents who were tested for Tay-Sachs disease, an autosomal recessive disease which has serious neurocognitive progressive disorder, and the children often die by the time they're 4 or 5 years of age. Often in the Ashkenazi Jewish community, also in the French Canadian and several other small isolated communities. The researchers found that 10% of adolescents who tested negative for Tay-Sachs said that they would never marry a carrier. And the researchers' conclusion is they didn't get it, because it's an autosomal recessive condition, and unless both partners are carriers, the children aren't at risk. I argue they did get it. But that 10% we're telling you is I view those people as stigmatized, and I don't want to have a child who will be labeled or stigmatized. So I think we have to acknowledge that this whole notion of carrier testing in a place like a public school, which has less voluntariness and which may have more problems about maintaining confidentiality, the school will say, well, we're not going to tell Johnny what Steve's result is, but Johnny and Steve are going to be sitting there in a group with their piece of paper, that I think we have to acknowledge that it's a very inappropriate venue on the grounds of issues of voluntary consent, as well as the issues of maintaining privacy and confidentiality. And that's why I said I'm totally against any type of school-based carrier testing. So what are the arguments against allowing adolescents just in general to consent for carrier testing on their own? Well, one argument is that even if they are GILIC competent or they have decisional capacity, that's necessary, but it might not be sufficient for healthcare autonomy. There are plenty of 15-year-olds who may have the decisional capacity to vote this November, but they're not going to be allowed to. The moral arguments of why we protect children or we prevent them from utilizing their own autonomy is that we distinguish between their short-term autonomy and decisions that they may make now versus their long-term autonomy. So we don't want to allow them to, in a sense, restrict their opportunities. We require them to go on through school, even if they don't want to, because we think it offers them greater long-term autonomy. The child's autonomous decisions will be based on limited world experience, and so therefore may have poor judgment. And it also denies the fact that parents have rights and responsibilities. There are also pragmatic arguments for ignoring an adolescent's autonomy. First of all, there's no valid test for competency. And so what it basically comes down to As a physician, I've never been trained in determining whether an adolescent is mature or not. What it basically comes down to is if I agree with your decision, you're mature. And if I don't agree with your decision, you're immature. So as long as I'm the one who gets to decide who has and doesn't have decisional capacity, the world looks pretty. But if you guys get to make that decision, we're going to be in disagreement. There are other pragmatic arguments. One is that parents should be encouraged to respect their child's evolving capacity. I actually think it's a really great idea for parents to allow their children to make many decisions. And yet, I'm not going to require that. That's my style of parenting, and some of you may really disagree with it. And finally, I think we have to put healthcare autonomy in perspective. We don't allow children to make many other decisions about what religion they are, about whether or not they go to school, about what activities they're allowed to participate in. Why have we isolated healthcare as an area where they are able to make better decisions? There are additional arguments against adolescent autonomy specifically related to genetics. First of all, genetic information is probabilistic and ambiguous, and it's clear that most Americans do really, really poorly in understanding probability. It's also true of doctors. Genetic information has implications for third parties. So it'd be an interesting thing to allow a child to get tested because it violates, in a sense, the parent's right to privacy about their own health risks. And finally, as I've already argued, that the genetic screening for carrier status in the schools is truly ethically problematic. It is ignoring the voluntariness as well as the rights to privacy. So why, though? What legitimate rights could a parent have in predictive genetic testing or carrier testing of their child? I think that it comes down to the main principle of all pediatric ethics. Parents have an obligation to do what they perceive will promote their child's interests. Their obligation doesn't abruptly end when the child becomes an adult, although the expression of that obligation, where I might be able to force my child to do something under the age of 16 and might have to start just becoming an absolute nag over the age of 18. And it also fails to acknowledge the right to consider family interests. I don't mean that we can sacrifice one child for the good of the family, but we may be allowed to compromise some of a child's needs. You have two children, one school's better for A, the other school's better for B. You don't want to deal with two different school schedules, so you put them both in school A. We don't always act in each child's best interest, but we have to at least act in all children's good enough interests. So what role for the adolescent? I would think that we should think about carrier detection and predictive genetic testing of adolescents as akin to an elective surgery like cosmetic surgery. While it's not wrong for parents to want this information, even over the child's objections, medical interventions require the participation of third parties who are moral agents themselves. So as a healthcare provider, I can say to a parent, I understand you're the boss, but if I have a child refusing here for something that's not medically necessary, as a moral agent, I'm refusing to do it. So physicians may refuse to test a teen if the parents want it without the child's assent. But what that might do, and I think we have to acknowledge this, is that it might push the parents to start looking to test their children younger. So if you tell me I can't do predictive testing of my children, I can't do it prenatally. As such, the requirement for requiring adolescent assent, we have to at least acknowledge that it may force parents to do it at a younger age, even prenatally, and that may expose, particularly in the prenatal period, the fetus to more harms. Nevertheless, the requirement for adolescent assent, I would say, is not too restrictive, and that if we've waited until this age, that the adolescents do deserve some control over their own bodies, acknowledging that sophisticated parents may then decide to do these decisions at a much earlier age, and that in the reproductive context, adolescents may need to consent for themselves for carrier status information. It's the adolescents who are having children at age 16 and 17 who aren't doing a lot of reproductive planning, I would suggest. So I'm not sure they're really coming in for that reason. So how am I going to revise all of our policies? Right now we have predictive genetic testing is considered taboo. Let me suggest that parental discretion for predictive genetic testing for childhood onset conditions should be respected. The adolescent's roles I'll describe in a few seconds. That predictive genetic testing for late onset conditions should be viewed as akin to elective procedure. There should be a presumption against testing. However, families, not clinicians, should decide whether the benefits outweigh the burdens. Carrier testing is considered taboo. Let me suggest that the policy, again, is that carrier testing should be akin to elective procedures. The presumption should be against testing. However, families, not clinicians, should decide whether the benefits outweigh the burdens. This notion of the growing acceptance of adolescents consenting for themselves, I would argue we should revise that policy as well. The adolescent's consent alone is not and ought not to be sufficient for predictive testing. Nevertheless, if parents want it, the adolescents they sent should be taken seriously, acknowledging that parents may get around this by testing their children younger, but also saying that the adolescent's consent may be sufficient for carrier testing in the reproductive context, but this does not justify programs, screening programs in schools. So on that note, having challenged all the policies, I look forward to the panel.